I'm Aman Shrestha representing Amakomaya from Nepal. Amakomaya actually means mother's love in English. But before going to Amakomaya, let's know something more about Nepal. Well, Nepal is a landlocked country between India and China, and it is ranked 157th in Human Development Index, and where more than 83% of the population live in rural areas. Now, if we see doctor to population ratio, there are one doctor for 5,000 population, and one nurse for 2,000 population, which is very, very scarce. And the maternal mortality is 157 per 100,000 live births. And if we see the neonatal mortality rate, it's 33 per 1,000, which has been stagnant for about a decade now. Uh, and the major causes of child mortality are pneumonia, diarrhea, and malaria, which can actually be minimized through preventive cure measures. Now, why mHealth in Nepal? We can see the majority of population are exposed to health information via radio still now, and it's only 60%. It has been approved by Development Resource Center, and more than 75% of the population use mobile phones now. A majority of people live in rural areas, but there is still no use of ICT to transfer the medical knowledge from urban areas to rural areas. And that is why we need Amakomaya, which is mHealth initiative actually. Now, it is an initiative that has evolved over time. We didn't really plan to go straight to mobile devices. It was initiated since 2000 to 2012, and it is the only initiative in Nepal now which actually provides educational contents to rural people. Now, the inception of the initiative took place by our team leader, Mr. Rajendra Prasad Paudel, who actually started showing video contents to villagers in Nepal. And as he was doing that, he received a community grant worth of $4,000 from Internet Society. And with the support of internet students and the $4,000 that he got, he developed a web-based application, which actually looks like this at the moment. And this web-based application was actually piloted in several villages of Magdi district, which is one of the most remote and mountainous region in Nepal. But he found that there's very little computer as well as internet connection, so which inspired him to develop or use an alternative tool that would be mobile device. As he was doing it, he got funding support from ISIF Asia and developed a web-based application. This web-based application is now under its piloting phase in 7 villages of 4 districts in Nepal. All the applications and the contents are localized in Nepali language, and it is very, very difficult to find any kind of contents that are in Nepali language. That is why we ourselves have created these contents and have approved it from the government. And this is how the application looks. Here, after creating the account, she can actually log in with her username and password. Actually, it's pregnant woman. She has to enter some basic informations like last menstruation period, her mobile number, and her age, and with the code from for health post, we track her on which location she is. And as she creates this account, she straight lands to her stage relevant content. As you can see here, it's the 30-second information that she is getting, and here's a notification that says she has to go for third ANC visit. And then you can see we have tried to use as much graphics as we can so that everyone can understand it. And we play 3 different contents from video, audio, and text. Apart from this, all these informations are saved in health post workers account so that they can filter the data. As we can create the count through it, the female community health volunteers may try a dummy variable. So what happens is that needs to be filtered in a place where it has to meet the health management information system of the country. That is why we have saved everything, and through this they can actually track how many of the pregnant women are there in the village and under which stage they are, and they can actually work according to it. Now, we also gather information about the antenatal care visit. according under WHO, and all those data can be transferred to our web server, and this is how it looks. It is a data from a village called Tistung, and if we click on the name of the pregnant woman, these are the information that we can see. She has visited 2 of the ANC visits, and still 2 of those are still left, and where she has done it. We can also know if she has done it in the health institution of the village or another health institution. Now, we can't really give the mobile devices straight to the rural people because the education level is very very low, and it will be very difficult for them. So this is the health system how it looks at the moment. The FCSV works as a bridge between health institution and rural pregnant woman. She visits both the places with very basic IEC materials and some basic medicines. But now, if we provide mobile devices to them, the use of the devices, everything can be changed, and the health knowledge in health workers as well as others can be increased. So now, using this framework, we have actually created some outputs like more than 650 pregnant women have been registered from 7 VDCs, and more than 40 FCSVs, female community health volunteers, can use it. And health posts actually report that the ANC visit is increasing as they have been using the application. And the local stakeholders are also very eager and advocating about the use of mobile devices. We have also been able to influence local level government investment as well as district level policy. And on the 23rd March, the local development officer actually announced that they have created a provision for Amakomaya for the upcoming plan. And that is not all. We have some other works to do in our future. We will be now developing localized contents, partnering with Read Nepal, partnering with the service providers. We will be utilizing the mobile devices and using SMS system in it, and we will be collecting comprehensive data through FCSVs by training them. And we are also trying to connect rural and urban health workers so that the medical knowledge from urban areas can be transferred to rural areas, and we will be doing research work for policy advocacy. That's it. Thank you.
Thank you, Mr. Shrestha.